Hello, everyone, and welcome to another installment of our Career Chats videos. I am Joan Dixon, Director of Student Programs at Gulf Coast South Area Health Education Center. It's a really long name, so we usually just go by AHEC. And what you can see on the screen here are the 6 student programs that we offer, all absolutely free of charge to you. You can go out and take a look at our Health Careers presentation on our website to get an idea about all the different health careers you can explore when trying to make a decision for your future. We have, of course, our Career Chats video library. We have many chat videos recorded in there from different doctor specialties, nursing specialties, pharmacists, radiologists, respiratory therapists, techs, counselors, educators, you name it. You can go out and watch those little career chat videos and see if that career sounds interesting to you. We do our health career camps in the summertime. I also work with HOSA Future Health Professional Clubs within the school system. So if you're in a HOSA club and would like for me to help you prepare for your regional, state, and international competitive events, give me a call. I have a public health internship program you're welcome to apply for. And then once you go into college and you're in a graduate level program, we have our intense 2-year scholars program teaching graduate level college students all about public health. So remember, plenty of free student opportunities for you in our 4-county service area of Charlotte, DeSoto, Sarasota, and Manatee County in the state of Florida. My website is on the bottom, along with my phone number and my email address. Let's jump right into our guest speaker for today. I am very pleased to have Dr. Isaac Calvaria on with me today. He is a gastroenterologist. And for those students who may not be familiar with this particular healthcare specialty, a gastroenterologist is a medical practitioner specializing in the diagnosis and treatment of disorders of the gastrointestinal tract and related organs. For example, a gastroenterologist treats these parts of the digestive tract: the stomach, the esophagus, pancreas, gallbladder, large intestine, small intestine, liver, rectum, anus, colon, and bile ducts. That's a lot for a specialty to all wrapped up in one. Welcome, Dr. Calvaria. I'm excited to hear about your career journey. Thank you for joining us today.
Thank you very much. My pleasure. Thank you for the introduction.
Absolutely. And we're going to jump right into the interview questions. First, I need to let students know that as far as your educational background, when you went to undergraduate and you went to medical school, you went to college, you were in Rhodesia and you were in South Africa. So it's not a normal educational track when in comparison with what we have to do in the United States as far as medical school. So it's a little bit different the way you took your educational track to become a doctor, and you've been practicing in the United States for many years now. So I just want to remind students that if you want to become a physician in the United States, it's 4 years undergraduate college, 4 years medical school. Then you can go on and you can do your residency, and depending on your specialties, how long your residency, and then you can specialize and go into fellowships, and you name it. It's a lot of schooling. That having been said, the job description, Dr. Calvaria, did I hit the nail on the head? Did I leave anything out from what you do?
You got everything right. And I was kind of chuckling to myself because when you described all the different organs that we talk about, we like to abbreviate it as M2A, which is mouth to anus. And I hope that doesn't gross anybody out, because somebody's got to take care of the other end as well. And we are privileged to do that.
That's right. Everybody does. In fact, there's that famous children's book that says everybody poops. Everybody does it. Right. We've got to take it. It's a very important part of our health as well.
Yes.
Now, when you're working in the hospital or working with your patients, describe to these students, what is the atmosphere like when you are in the hospital? What's your day like?
Yeah. So I interact with many, many professionals. My day is sort of divided between hospital, clinic, and endoscopy center. And I can talk a little bit about endoscopy in a while. But basically, I vary. I will often start making rounds at the hospital early, sometimes even 6 a.m. or even earlier than that. I like to get things done before anyone else is around, so I have the full attention of the nurses. And sadly, sometimes we have to wake the patients, which is not a good thing, but they need to see us. And then I will spend, once I've finished my hospital rounds, I'll spend some time in my clinic. And in my clinic, I will see patients for several hours. And then we'll often go to the endoscopy lab where I will do procedures. Sometimes those days get flipped around depending on my relationship with my partners. So that is basically what the day looks like. The atmosphere is constantly what we call collegial. I'm constantly interacting with wonderful people, each one of whom is absolutely necessary. It's like a huge puzzle. If you've got a piece left out of the puzzle is not complete. And so I'm interacting with lots of people. And I think you probably are going to ask me, I think that's probably the next question, is the health professionals. So I've got my nurses. I've got my mid-levels. Now, you may not know what a mid-level is. A mid-level is someone that works underneath a physician. And a mid-level will be someone like a physician's assistant or a nurse practitioner. And I'm wondering, by the way, you may have access to interviews with mid-levels. They are going to become the primary caregivers of the future. And the reason is that we physicians are retiring, we're getting burnt out, and we're training these wonderful young people that come out of physician assistant school or nurse practitioner school, and they are kind of the conduit between us and the patients. So the mid-levels. And then I've got of course, my reception staff. I've got anesthesiologists that I work with. These are the people that put our patients to sleep for procedures. I've got the surgical techs. Surgical techs stand next to me. And if I think of wanting a piece of equipment, I have a surgical tech who reads my mind. If I think that I want a piece of equipment, it's in my hand. Radiologists, because we do a lot of x-rays. Surgeons, we communicate with surgeons about different types of procedures. Cancer doctors and radiation therapists, just to name a few. So my day is full of wonderful interactions with incredible people.
Sounds like quite a team, and I'm glad that you mentioned that because doctors don't work alone, not by a long shot. Many
Not at
different
all.
members of the team.
Well, especially if you're seeing patients. I mean, there are, of course, people that are pathologists or people that are radiologists that tend to work kind of in a solitary fashion. Again, we need, by the way, I forgot to mention pathologists, of course. Those are also people we interact with. But if you want to physically be seeing patients, there is a whole team. What's that expression? It takes a village, and it sure does.
Now, correct me if I'm wrong, but isn't it a unique situation in that not only do you see patients, but that you also do procedures, and not all doctor specialties do that. Not all doctor specialties do procedures.
Yeah, exactly. And we're going to come to this question, I think, a little bit later, is why did I choose this profession, this particular specialty? Is because it gave me a wonderful combination of cognitive approach, in other words, thinking about problems, and then actually solving them by looking inside people's intestines. So it's cognitive and procedural. And there are, as you point out, very few specialties where you have this wonderful combination of thinking and doing. And they complement each other. They work together. And that's why I chose this profession, actually.
Now, over the years, since we covered all the different organs that you have to take care of, is there any more common procedures that you take care of? Or do you, like every day could be anything?
Yeah. So the majority of our procedures are what's called an endoscopy, which is where we take a very thin instrument around the size of your little finger. We put it down through the mouth and we examine the organs such as the esophagus, which is the swallowing tube, the stomach, and the duodenum. That's probably the procedure we do most, but it's closely followed by a colonoscopy, which is a procedure that goes through the other end. And that scope is about the size of your index finger. And with that, we look for things like Crohn's disease, ulcerative colitis, polyps, cancer. With the upper scope, we look for things like acid reflux, ulcers, celiac disease. And so we can diagnose a lot of illnesses with those two procedures. Those probably make up about 90% of my procedures, but I'm also specifically trained in a procedure that is a higher level where we can pull gallstones out of the bile duct without surgery. In fact, that's the reason that I was recruited to the United States, because we were starting to do this in South Africa, and very few people were doing it in the United States. They wanted me to train people how to do that. That is a higher level procedure. And there are also some other things that we do very rarely, but those make up probably about 98% of our procedures.
I can tell you from personal experience, I am very grateful for the work that gastroenterologists do, especially when I had to have my emergency gallbladder removal.
There you
Yes, yes. So thank you. Thank you
And
to gastroenterologists everywhere.
that special procedure that I do that I was recruited for is called an ERCP. And if you had gallstones, you might have had a stone in the bile duct, which is removed. It used to be removed with a very long scar that size. Now we can remove it through the mouth, pulling it all out like magic. It is an incredible procedure, and it doesn't leave any scars. And patients basically go to sleep and wake up an hour later, and it's done.
That would have been fantastic if I had that option, because mine was plugged up, and they had to remove the whole thing. So
okay.
Yeah, they got me in and out real quick.
But I presume it was done laparoscopically, which is the minimum surgery with the little incisions, these ones. Now, only 30 years ago, the incisions was that long, and you would have had to stay in hospital a week or 10 days. So this is a major advance, but that's not something we do.
Yes.
We don't do laparoscopy.
Yes, a lot of major medical procedures have evolved. And this is something I wanted to touch on as well, because as a doctor, you're never through learning, are you?
Correct. Well, I mean, what we say is the more we know, the more we realize we don't know. So I get a journal, 2 or 3 journals every month, and each one has an advertisement for some new device that is designed to make our lives easier. I'll just tell you what I got yesterday. There are some people that accidentally or on purpose swallow things they shouldn't swallow. For example, watch batteries, knives, springs, all kinds of things, and we have to fish those out. And so someone wrote an article showing us all the different instruments we have to fish these things. Oh, safety pins, open safety pins. That's a challenge. But there are ways to do all that. So the procedures are constantly evolving. More and more people are developing new techniques and inventions to help make things easier and safer.
And you have to do continuing education credits each and every year as well.
Yeah, it's 40 hours every 2 years. And this is not something that I have to do. This is something that I want to do. Because if I didn't have to do it, I would still want to do it. How else am I going to stay on top of the new advances unless I'm reading all the time? So this is really part of the ongoing growth. And remember also, medicine is sort of an art, not a science. If it was a science, we might have figured things out. But it's an art, meaning that each person is different. We're not looking at diseases. We're looking at people with diseases, and each one is different. So that's why we need to keep learning, so we see all the different variations on a theme.
So now that's a good segue, because you say each person is different, and you covered mouth to anus. So we're not just talking adults, we're talking children as well. Do you have a special age group that you prefer to work with, or do you cover the whole gamut?
I generally work with adults, but because we have a shortage of pediatric gastroenterologists, I will see people in the early teens, particularly if they have adult type diseases. So for example, if someone is 10 years old and has irritable bowel syndrome, I'll see that person because it's basically the same disease in a smaller person. Or celiac disease, which is a gluten allergy, or ulcers. I'm kind of an adult gastroenterologist, but I've pushed my age group down a little bit by personal request and depending on the case.
Understood. And you talked a little bit about your workday, sometimes beginning at 6 a.m., long days. How does that impact your personal life?
Yeah. Well, I've learned over the years to, and there's more and more being written now about work-life balance. And the reason to have work-life balance is to avoid burnout, because there are people that are totally focused on what they do and they don't spend any part of the day doing something fun, either for oneself or with the family. So I tend to finish at 5 or 6 p.m. in the office. I will go home. When our kids were home, we'd always have dinner together. I help them with their homework if needed. And then after that, I would get on the computer and I would clean up the day's work. So for example, if I needed to send some reports or do some dictations, I wouldn't spend that time in the office when I was capable of doing that from my home computer in the evening when the kids are asleep and I put out all the necessary home fires that need to be put out. And so I've sports that I play. I have all kinds of other things that I do, and it's very important to make certain you do that. Otherwise, if you're only focused in one area, and by the way, this doesn't only apply to physicians, it applies to everybody who is a busy person. You need to have some work life balance. Very important to do that.
When we're talking about starting out a career, what type of starting salary, a range, can you expect in this field?
Yeah. So some people might be disappointed to hear this, especially after all these many years of training. But you have to start off kind of a low person on the ladder. It depends on whether you're working for a hospital or whether you're working in a private practice. But generally speaking, don't expect more than maybe $120,000 to $150,000 a year, which is really not bad for starting salary. But remember, of course, that you have started your working life, your earning life, much later than someone who went to trade school, for example. So you've got time to make up. Now, if you're lucky, you might get up to 250,000 to start with, but generally not more than that. Now, that's the sort of bad-ish news. The good news is that once you become a partner in a group, or once you've demonstrated that you're able to perform well in a hospital, I'm not going to say the sky's the limit, but you can get up to close to $800,000 with the work that you do, plus the additional income, for example, from imaging and from anesthesiology and all the other little pieces that we put together to improve our income. But generally speaking, starting off 150,000, I would think, would be the maximum.
That still sounds like a really good salary to me. And as you mentioned, you keep working your way up and getting more money. Yes. And you talked a little bit about why you decided to pursue this career. And some students will say, well, I've known what I wanted to be since I was 5 years old. And people change their minds, and rarely ever is the career journey a straight path.
Sure.
How was it for you? Did you always want to be a doctor?
Yes, I wanted to be a doctor from when I was very young. And so my path to medical school was kind of, I predetermined that. But what about my decisions after that? Like, what specialty did I want to go into? Now, I mentioned earlier on that I was looking for something that allowed me to use my brains and my hands to solve problems. Now, there are specialties where you're only using your brains, like a primary care doctor or an internist. And by the way, those areas, we absolutely have a critical need for people to go into those areas. Your family doctor, your primary care doctor, your internist. These are people that spend their day thinking about problems. And then on the other hand, you've got the surgeons who spend most of the day operating. I decided that I wanted to have the sort of sweet spot where I have both the cognitive and the procedural. And by the way, I was helped in that by a professor. And how often do you hear this, that you have a mentor who was so special that you almost gravitated to every word that came out of that person's mouth? And this is the person who turned me on to being a gastroenterologist, a very famous doctor at the University of Cape Town. And after spending time with him, there was absolutely no doubt in my mind that gastroenterology was going to be what I wanted to do.
That's a wonderful story, and I thank you for sharing it. And I do recommend that students go out and they get out there and they job shadow and they talk to people if they have an interest, because there's no better way to find out if you're going to like something until you spend time doing that or talking to somebody who does that.
Yeah, well, what you don't want is to pursue something that you thought you wanted to do when you were 5 years old. And then you find when you're deeply into something that, this is really not what I wanted. So it's called doing your due diligence. We do due diligence in everything we do in life before we buy a car, before we buy a house, and before we get into a career. Do your due diligence. And there's so many people available that would love to guide you in whatever you want to consider doing.
Agreed. Students, I hope you're taking notes and paying attention. You get out there, you do your research, you contact them, see if you can job shadow, even if it's just for a couple hours a day, and maybe just once a week, just to get out there and experience it, and also do your volunteer opportunities at the hospital, because that's a great way to meet providers as well.
Absolutely.
And see what they do.
Absolutely.
What do you find least satisfying about your career?
Yeah, you know what? I when I thought about this question, I did not spend a lot of time wondering because I know what they are. The first is insurance companies, is getting authorizations for things that we know a patient needs, but an insurance company pushes back. For example, there are some wonderful new drugs available for colitis. And all the new drugs that are approved by the FDA, insurance companies don't want to pay for them because, they're more expensive than what we already have. But sometimes you really want to go, somebody's got a difficult problem, you want one of the newer drugs. And so we have to get on the phone, or our nurse has to get on the phone. Sometimes I have to get on the phone with a physician director at an insurance company after a 15-minute wait on the phone. So that is one of the issues. The second issue, the second thing that I don't like is the amount of computer work that needs to be done. Back in the day, when I didn't have all this gray hair, I would have a pad and I would write notes on the pad and we would put them in a chart. We don't do that anymore. Now, of course, it's all documented and there's more and more documentation, more and more questions that need to be asked and answered. And that takes time and it's annoying because you really want to get to what's important. What do I think is wrong with this person and how am I going to help this person? And that unfortunately often comes on page 10 of the notes. So all the preceding 9 pages, to me, they're not a waste, but they're not really what I'm interested in. So it's the bureaucracy of insurance companies and it's the burgeoning and increasing computer work that are the two negatives for me.
Well, Dr. Calvary, I can share with you that that's a common theme that I hear from doing these career chat videos. Number one, least satisfying, working with insurance companies.
Yes.
It takes away time that you have to spend with your patients too, having to do all of the paperwork and so on and so forth.
Now I have,
and then of course,
with regard to the computer, I have a style that has worked for me. That is, I have very little visibility of a computer when I'm talking to a patient. Very little. Because one of the things that I love is the eyeball to eyeball contact. People love that. Even if you can't help somebody, the fact that you've looked them in the eye and you've listened to them is very, very precious. So I try and do as little computer work as possible when I'm with a patient.
So we have to cover the flip side of what is least satisfactory by you telling us what is most satisfying about your career.
There's so many things, but I'll hit on a couple, and that is someone who has come to me for the third opinion, and they've had a problem for 10 years, and I just sit and listen to them, and we have an epiphany. The patient and I both have an epiphany, and we know what's wrong with him or her. In fact, my old professor who turned me on to gastroenterologist said to me, if you listen to people long enough, they will tell you what is wrong with them. Now, what is the average time that a patient can speak to a doctor these days without getting interrupted? 12 seconds. Okay? So if you let people speak, they will tell you what is wrong with them. So that's been my sort of shining light all these years. And so helping people, someone coming back to see me after a visit where sometimes it's not even a medication, I've tweaked their diet, or I've told them something about lifestyle, a back to basics approach. And they come back and they say, oh, wow, I feel so much better, and I'm not even taking a pharmaceutical. And the other thing that really gets me a lot of satisfaction is when I do a procedure and somebody is bleeding and I stop the bleeding and they wake up and they're no longer bleeding. So that is an immediate euphoria, an immediate high that you've helped somebody and maybe even saved a life.
I think it's important that students understand that going to the doctor is not just going and getting a prescription for a pill or having to get a procedure done. There are many ways that you can work with your patients to try and come up with something before you have to go to the medications or the surgery.
It's surprising how often just a return to basics solves the problem. How well are you sleeping? Are you seeing your friends? Are you going out and experiencing the sun? Just some really basic things. And one will be surprised how few people or how many people have forgotten the basics of life. And once they get back to that, sometimes whatever is ailing them, I say miraculously, but perhaps reliably just goes away, or they feel better.
Yes, everything can affect your health, everything. When now you've practiced for many years and now you're semi-retired. What are you doing now?
Yeah, so I'm doing two things. For a start, I feel like I have to give back to my community that's been so good to me. And so one afternoon a week, I do a clinic. It's called the specialty clinic, where I see people that have no insurance or people that have somehow fallen through the cracks. And it's almost a win-win. The patients obviously win, and I win because, again, it leaves me with a sense of having done something where I was not actually personally rewarded in a financial way, but I was rewarded in a spiritual and emotional way. So I do that. And the second thing that I do is I do what's called second opinions. I contract with a company out of Texas where if you want a second opinion, you get online and you put in second opinion, and this company comes up pretty high up. And then the nurses at the company ask the patient what particularly is your problem, and then they match the patient with a consultant. And so I do that, and these are difficult problems because by definition, no one's been able to help them, or they just need more education. And so that part of my life has grown tremendously because so many people now want second opinions, or their doctor has spent 5 minutes with them and they want some clarification. And it's a wonderful position to be in, to be able to help people in those scenarios. Also, by the way, if you want to get a second opinion from Mayo Clinic or Cleveland Clinic or wherever, good luck with that, because the waiting lists are now 3 to 6 months. Whereas if you want a second opinion with me, I just got one. I informed this morning, I'm doing it tonight. And so if I've got availability, I'm very happy to do that. So it's a very, very nice feeling for me to be able to do that. So second opinions and volunteering.
And that's a wonderful service that you're providing. And coming from, our little nonprofit organization all about public health and giving back to the community, thank you for providing that service to community members who need you the most.
Yeah. As I said, it's win-win. I get as much out of it as they do. So it's very good. And that's the same with any volunteering. I would encourage young people to do that as well. It's truly giving back to society.
Do you have an interesting case you worked on, or maybe a patient that made an impact on your life that you'd like to share that story?
Yes. Now, this was a young lady who was a dancer in her mid-20s, and she was bleeding from somewhere inside her gut, and nobody could find out where. Now, you can imagine a dancer can't really afford to be anemic. Anemic is the word used to describe a low blood count because you need tremendous energy to be a dancer. And she could sometimes not participate in recitals or programs because she was anemic. And we did the endoscopy and we did the colonoscopy, and we couldn't find anything at all, multiple occasions. And then we decided we would do a capsule endoscopy. Now, this is a wonderful invention. It is a capsule the size of a vitamin pill, and it's got 4 lights on it. It's got a video chip, it's got an antenna, and it's got 2 batteries. You swallow the pill, which is about the size of a vitamin pill, and it sends 50,000 images of your small intestine to a computer that you wear around your waist. This little capsule is pooped out, it's gone, it's disposable, and then we take the computer video and we watch it. And in this particular young lady, she had deep in her intestine, in the dark area where we could never reach with scopes, she had what's called a hemangioma, which is a collection of blood vessels. We could see it so clearly on this test, and this is what was constantly bleeding. And we could describe to the surgeon where this was, and the surgeon went in and removed a little section of her small bowel, and she could dance again. So this was using, and by the way, that technology is now 30 years old. It's not new, it's 30 years old. It's incredible.
That's amazing. That's a wonderful story, and it's definitely one that you keep with you because of the
Absolutely.
difference that you made where everybody else couldn't figure it out. And
Absolutely.
that's a
Yeah,
wonderful story. Now tell me today, we talk about how long you have to be in school and all the skills you have to learn, but also social skills is a very big part of being a doctor as well, and how you interact with your patients. And they call it the bedside manner. What's
yes.
going on with doctors and patients interactions nowadays?
Yeah, this is a sad situation that's happened, and it's almost inevitable because people have gotten very busy. They have less time than they had before. It's almost like being on a treadmill, and the treadmill constantly is throwing you off. You've got to produce, and you've got to not only see the patients, but you've got to do the computer work as well. And also we've got more and more doctors retiring, hence the importance of what I call the mid-levels, the physician's assistants and the nurse practitioners. But I have never swayed from what I learned as a student is to shake somebody's hand when you see them, look them in the eye, listen to them, even if they're saying something that doesn't sound logical, it is something that comes from them. It needs to be explained. That if there's not much you can do, you need to reassure. If it's a common problem, you need to tell them that there are lots of people with that kind of problem and there are answers for this. My strategy always used to be that my patients had to leave my office happier than when they arrived. Now, if I had some miserable patients, I would sometimes just tickle them because they knew my philosophy. You had to leave happier than when you arrived. And when you it's the same with, I think, every single profession. When you do that, you are instilling a sense of hope and a sense that something good is going to happen. And to me, it's a lost art. And this is, by the way, the art of medicine, not the science. The science is prescribing a medicine. The art is listening to people, giving them validation, and telling them that their symptoms are important and you'll do your very best to help them. And
Well,
unfortunately, it's the lost art.
I I would hope that they're covering that in medical school, but I think it seems to be lost in translation
Yeah.
somewhere along the way.
I think it's probably covered in medical school, but when you go out into the working environment, the pressures, I think, overcome all of these good intentions. The pressures to produce, especially if you're working in a hospital, you're expected to see so many people per day. If you've got a couple of people that take more time, these doctors, they get a little bit antsy. They have this thing, what do they call it? The hand on the door phenomenon. In other words, your physician is leaving. He's got his hand on the door and he wants to leave. And the patient says, oh, by the way, I've been having this crushing chest pain. And you've got to take your hand off the door and you've got to sit back down again. You've got to listen to it. I've also we've got some instructions or some recommendations we give to our patients as to how to come to the office, what to do, what to bring, send records in early. Bring somebody with you. 2 brains, 2 sets of ears are better than 1. And so we try to get back to basics, not only on the way we approach things, but on the way our patients come into us and what their expectations are.
Good advice. And speaking of good advice, our last question that we have for you is, what piece of advice would you give to students who are interested in being a physician, maybe can't determine what specialty they want to go into? what advice
Yeah,
would you
yeah,
give them?
yeah. Well, we kind of touched on this earlier on, is to, if you've decided that you want to become a physician, try to expose yourself to as many different specialties as possible. I think one initial sort of fork in the road is, do you want to be actively involved with seeing people face to face? Or do you want to be in a situation where you kind of prefer being a loner, but you still want to be in the medical profession? There's plenty of room for that, like pathology or radiology, that, or even working in a lab. So I think that is one fork in the road that you've got to decide. I want to be a doctor, but I want to be a doctor that deals with people. All right. So then you are down one algorithm. And then find, maybe do some reading, listen to videos like this, opinions from people that have done it. And then find yourself somebody that you can attach yourself to, someone who can be a mentor, even for a couple of days. You may say, oh, I cannot do that at all. I was once doing a procedure with someone who wanted to see what I did. And as I put the scope down, there was a thud behind me, and that person had fallen to the ground. Okay. So we know that's not a budding gastroenterologist. Okay. So yeah, expose yourself to all of this, because that's the only way you're going to know.
Very good advice. Yeah, if you're going to faint when watching those procedures, probably should consider a different line
Yeah,
of
yeah,
work with
exactly
that.
right. Exactly right. Yeah.
Thank you so much, Dr. Calvera, for being here with us today, answering all of our questions, telling us about your journey and about your career. I believe this interview will give students a better understanding of what gastroenterology is all about. And I believe that they will take away the good advice that you've given them about how to choose a career, get out there and research and explore, find it out what it is that you like to do. And I'd like to take this last moment to remind students that we have many programs available for you. You can email me, jdixon@gsahec.org, or you can call us. You can look at our website to get more information about our programs. All the information is on the screen right there at the bottom. You can always hit pause when you're watching this video and to give me a call or send me an email. Thank you again, Dr. Calvaria. I hope you have a wonderful rest of your day.
Thank you, Joan. You too, and good luck to your students. Thanks very much. Bye-bye.